Thanks, Eric. Great to be here. To see all the New York friends, and this is like it's unfortunately a once a year thing sometimes. Seeing some of these friends, but hopefully we'll do better in the coming years. Okay, we're talking about the data situation with pulmonary embolism. Big switch of topic, and you can see there are clots involved this time. So here are my disclosures. Of note, none of these are direct payments to me. And I will be discussing the first in detail, the first bullet point here. If we look back at the last 8 years, it's quite impressive actually. 2014, the PYTHO systemic thrombolysis trial was published, and the Ultima trial, which was the only RCT for catheter-directed thrombolysis, was published. Then in 2015, you have a couple single-arm studies, Seattle 2, which evaluated the ecosonic catheter and the PERFECT registry. 2017 was a focus on the long-term effects of pulmonary embolism with these studies. Both the ELOPE study really highlighted the incidence of post-PE syndrome in patients who've had a first PE. And then in 2018, we started to see both a refinement of the dosage of catheter-directed thrombolysis, as well as the first thrombectomy single-arm study was done. 2019, the second thrombectomy study was done. And then 2022 is looking very interesting, very busy, very exciting, with some caveats. But these are some of the studies that have completed or are in process and in progress. And some of these are of very high, rigorous standards to really advance the literature from where it is now. So these are the catheter therapies that we have currently with a fibrinolytic drug. The one on the left is the oldest and is the standard infusion catheter. The one in the middle is the ultrasound-assisted catheter, the ecosonic catheter, and the newest to the group is this device from Thrombolex called the Bashir catheter, which comes straight, but then when you pull back on the toggle at the back end of the catheter, it opens up into this sort of shallot appearance with 6 different infusion limbs through which the infusion drug goes. So let's look at all of the CDT trials that have been done. This is a sort of listing of them in a kind of color-coded way. Of these, only the Ultima study is actually randomized to anticoagulants. The rest, some others do have randomization as part of their design, but not to anticoagulants. And so if we were to summarize all of those studies into what we could actually determine, we could say relatively confidently that CDT reduces the RV to LV ratio by echocardiography 24 hours after intervention. That's it. There's no other real conclusion we can make from the catheter-directed therapy literature other than this in terms of determination or causation. We do have associations with RV to LV ratio reductions, including Seattle 2, which was the first study to sort of kick off this sort of evaluation as a primary endpoint for single-arm studies. And then the question comes up, well, is there bleeding associated with catheter-directed thrombolysis? The ideal is that you get the same benefit from systemic lysis, which did show an overall clinical benefit, but had too high of a bleeding rate to be routinely used. So can catheter-directed therapy overcome that safety issue? Well, Seattle 2 did have an 11% major bleeding rate. Now, some of them were access site bleeding, and some of that has been corrected with subsequent techniques, but it did show that bleeding can happen with catheter-directed thrombolysis, and but it did not have any intracranial hemorrhages. The Optilice study that followed did have some bleeds as well. So this was a concern for catheter-directed thrombolysis. Perhaps it isn't as safe as we thought it was. Overall, though, there's been a lot of studies looking at catheter-directed thrombolysis, and we're coming around a point estimate of about 0.3 to 0.4% for intracranial hemorrhages and about a 5% major bleeding rate. That doesn't mean it's the end of the story. This is just recently published data from the Thrombolex Rescue PE study. And this was also a single-arm study of about 109 patients. You can see that like the other studies, there was an RV to LV ratio reduction, but there was also a pretty impressive thrombus PA obstruction index reduction of 36%, which was the highest we've seen so far in these single-arm studies. And this was done with a very, very low major bleed rate of less than 1%. There were no intracranial hemorrhage rates, and with a pretty modest amount of TPA, so 14 milligrams total were given in this study. So a very interesting signal. I think we are getting better at lowering the bleeding rate with catheter-directed thrombolysis. Are we at the final protocol? Probably not, but this is showing a sort of progression, hopefully, in our ability to reduce bleeding while increasing the efficacy of the procedure, and perhaps innovations like the Bashir catheter will continue to help us. In response, though, to the bleeding seen with catheter-directed thrombolysis, you have these devices that have entered the market that promise to remove thrombus without the use of a thrombolytic drug, and these are some listed here. And two prospective studies have been published, as you saw on the first slide, FLAIR and Extract PE. FLAIR was published in 2018 and Extract PE in 2019. And on the horizon, we have these devices that are starting up their single-arm studies along with a slew of others. And there is an interesting study going on right now looking at thrombectomy versus thrombolysis that is sponsored by Inari Medical. I'm not going to go through the details of this, but again, this is not a comparison of catheter-directed therapy to anticoagulants. It's kind of a technique-dependent study. So if you look at efficacy across these prospective single-arm trials, it looks pretty good across the board. They each seem to reduce the RV to LV ratio by about 0.4 to 0.5. So what does that mean? Is that good enough? Should we be treating patients with this based on this data? And my argument is a resounding no. And it's primarily for this reason. None of these studies other than Ultima has compared these devices to an anticoagulant group. So all of these outcomes, RV to LV ratio, obstruction, death, deterioration, exercise capacity, quality of life, we don't know how these compare to prompt anticoagulation, close monitoring, best supportive care. And really, the reason we can't convince the world that this is the right thing to do is for two major reasons. The first is a lack of randomization. Compared to 1,500 patients in systemic lysis trials, only 59 have been randomized in a single non-US CDT trial. Our clinical outcomes data is insufficient. The RV to LV ratio is a surrogate marker. Yes, it is a marker of bad outcomes. However, we need to know how CDT is doing in terms of hard clinical outcomes, which we don't have right now. The guidelines agree with these conclusions, and there are about 6 that basically say the same thing, that there's a weak recommendation when it comes to catheter-directed therapy or no recommendation for it in the setting of submassive PE. So fortunately, we are moving forward and trying to correct these data gaps. In the short term, the Boston Scientific is sponsoring a study called HiPytho, which is an international study looking at short-term outcomes after submassive PE. But we're excited to announce that PE Tract has finally funded and has funding from the NHLBI and will be examining the medium to long-term aspect of this disease. And this is a sort of illustration of what HiPytho looks like. Intermediate high risk PE with proximal thrombus. And this is kind of an enriched population because they also need to have 2 of the 3 features seen here. But their focus is on the short term, whether they can reduce the composite of mortality, recurrence, and clinical deterioration within the first 7 days, which is different than the thrust of PE Tract, which kind of harkens back to this idea that 40 to 50% of people are going to have some version of the post-PE syndrome with poor oxygenate or peak oxygen consumption on cardiopulmonary exercise testing 3 months to 12 months after their PE. So this is PE Tract, catheter-directed therapy versus anticoagulants. Now, this is the best endovascular therapy for a given clinical trial site, so it's not specifying what type of, whether it's lysis or thrombectomy. It is a broader category for the inclusion because we're looking at medium to long-term rather than acute deterioration and death. The primary endpoint is a cardiopulmonary exercise test 1 combined with an NYHA class at 12 months using a gatekeeper approach. It's a little bit complex, but the idea is to both get a physiologic and a patient-centered assessment. 500 total patients with a interim analysis starting at 250 and every 50 patients thereafter. But it's not the only thing we're looking at. We are looking at short-term endpoints, the 6-minute walk distance, quality of life, really a whole group of outcomes that will help us get a better understanding of this. And ultimately, we're asking the question whether CDT results in better long-term clinical outcomes. So PTRACT is correcting some of the data gaps by having these features. It has equipoise. It is the only non-industry sponsored study out there right now. And I think that is very, very important as we look at what endpoints we're trying to achieve and are we really doing the right thing. It has true randomization against anticoagulants alone, has a large sample size. It addresses the unknown effect of CDT on long-term exercise tolerance, systematically describes short-term outcomes, rigorously describes the safety of CDT. With 500 patients, we'll get a much better point estimate. And we also include a badly needed health economic analysis, which will tell us whether this is a cost-effective therapy. So all of the New York sites, fortunately, will be PTRACT sites, which is great. But that being said, if there's any interest in being a site for PE-TRACT, please email me. My email is very simple, asista@gmail.com, and we'll start the assessment. So in summary and conclusions, there's a long pipeline of pivotal device trials. It's exciting, but at the same time, we've got to be careful to pick the right ones that are actually going to move the field in the right direction. There are complementary randomized trials, and we need to prioritize these. And I will especially say that PE-TRACT is the most important of these. It's the most independent. It is looking at this in the most rigorous way with the most equipoise. And if all of these trials are completed, and that is the important word is if, we will usher in a golden era of PE care, and I would warn that that does not necessarily mean that we'll be doing more procedures. All right, thank you very much.